I'm just sending them a message. Okay, we are live now. Thank you, Councillor.
Good evening and a warm welcome to all members of the Health Overview panel at Kingston and to members of the Health and Wellbeing Board. I'm Councillor Anita Sharper and I'm Chair of the Health Overview panel, and I'm here this evening with our co-chairs of the Health and Wellbeing Board, Dr. Naz Javani and Councillor Emily Davey. I'd also like a warm welcome to the public who may be listening on the Council's live streaming service. This is a extraordinary occasion and situation, really, and I really just wanted to say which has really sort of brought us to this evening's joint seminar taking place. I want to pay a tribute really to the many helpers, NHS staff, carers, volunteers, friends and neighbours who have given their time, expertise, energy and enthusiasm and support during this pandemic. I'd also like to pay tribute, sadly, to all those who have lost their lives, and our thoughts are with their family and loved ones at this time. I also would like to just say a very brief statement from a resident who I said I would mention a few words on his behalf this evening, from a Mr. Rob. I just wanted to say very briefly, on behalf of the residents and patients of the Royal Borough of Kingston, we would like to say a big thank you to all the NHS staff, GP surgeries and pharmacies, community care workers, care home staff, palliative health care team, and all the other people involved in keeping us safe during this crisis. They and their families have put their lives on hold and on a daily basis put their lives at risk on our behalf. And I just wanted to just end his statement. We should not underestimate what they have done and what they're doing on our behalf, and every one of them should be very proud of themselves. So I just wanted to say that statement for Mr. Rob. And then just very briefly, I wanted to just do a couple of items of housekeeping. If we can all keep ourselves on mute unless we're speaking, I think that would help. And then also to mention, we're on quite a tight timeline tonight. So obviously we have quite a heavy agenda of 11 items. What I'd like to do, I'm going to do my best to try and get everyone's questions featured this evening, those who want to ask a question. I think what I'd like to do though is just to say that after every item there's going to be a chance of a Q&A. So and then what I'm probably going to aim to do at about 5 to 8 is have a 5-minute rest, whatever we want to call it, quick break, and then resume at 8 o'clock if that's going to be agreeable for everybody. And then, as I say, I'm going to try and aim for about 3 or 4 questions after every item, just because otherwise we're not going to get through all the 11 items in the time available. So I'll do my best to try and keep the chat eye on the chat box. If you'd like to ask a question, just put your name dash, so just first name dash, and if you'd like to speak, and I'll keep an eye on the chat box for you. So that's really just the housekeeping items. And I think I'm going to now hand over to Iona Liddington, who is going to present the first item on the agenda. Many thanks. Thanks, Iona.
Thanks, Councillor Schaper. And obviously we've got a busy evening this evening, so thank you with the next slide for that very useful introduction. And I appreciate some colleagues are struggling with the sound, so please, if you could just check your mute button, your sound button, it's up. And for some colleagues, I think it does mean coming out of the system and rejoining, so apologies if that's for you. So could I have the next slide, please? And it's wonderful to welcome you here this evening to the seminar. As we've heard, it's a joint Health Overview panel and Health and Wellbeing Board opportunity to go through the COVID-19 response so far. And just to say, this is obviously the first phase of COVID-19. We clearly are going to have the virus with us for quite some time, yet nobody knows how long. There is obviously some news around a vaccine, but in reality is something that we will need to continue to make make sure that we socially distance, that we follow the guidance, and it's something that potentially we have to come to live with over the coming months. But clearly it has been a pandemic, it has been an emergency situation, and all hands have been on the pumps to try and respond to this pandemic. And that's really what we're going to be sharing with you this evening, and an opportunity to show you how the health and care system has worked together on this. So if I could have the next slide, please. I thought I'd just set the scene with a little bit of the timeline to date, and apologies, it's quite small font, but just to give you a sense of the sort of speed with which things have been changing. So if we think back to the end of December, and literally the 31st of December was recognised to the WHO by China of the first cases of a new novel, so unknown before, coronavirus, which we've come to now call COVID-19. And in January, there was national UK public health advice on preventing, so that precautions of catch it, bin it, kill it, the very strong hand washing message, which is still very much our main prevention mechanism, and the social distancing to try and prevent this transmission, which is largely through droplet form. And we started at that point contacting cases and contact tracing for cases. And the 31st of January was when the first cases were officially recorded in the UK. And say throughout February, those self-isolation messages for incoming travellers were put in place, and even more focus on that hand washing and personal care. On the 11th of March, the Chancellor announced his initial 12 billion package of support for the NHS, wider public services, businesses and others to help tackle COVID-19. And on the 12th of March, the next day, the WHO declared a pandemic situation. And the impact, using evidence arising from China, showed how easily transmissible this virus was, and how the health impact meant that a lot of people had to be hospitalised, and many ended up on respirators, and many sadly died. And in the UK, we moved from trying to contain the virus, recognising that it was community spread, it moved to the delay phase. On the 19th of March, we had emergency legislation introduced, and which came into law on the 25th of March, the Coronavirus Act 2020, which include a wide range of measures to try and support the response of the virus. On the 20th of March, schools closed, except the children of key workers and vulnerable children, and other premises, non-essential premises like bars, restaurants, were told to shut. On the 22nd of March, we had letters going out to 1.5 million people that were recommended to shield for at least 12 weeks. So those that were medically vulnerable and more likely to have the adverse impacts of COVID-19, recommended to literally stay behind doors, except for essential care, have support with shopping and medicines collection. And the council provided support to them, and we'll hear about those in Kingston that didn't have family, friends or trusted neighbours to assist. From the 23rd of March, we had the formal lockdown where people asked to stay at home, and that was really to try and suppress the virus and try and reduce the onward transmission to protect the NHS, which would ultimately save lives. And we're all very versed with what that meant for ourselves as individuals and our families, but absolutely for our communities and those that are most vulnerable. On the 10th of May, the Prime Minister announced a new plan to beat the virus and start to reopen society, so the COVID-19 recovery strategy. And on the 28th of May, we had the new NHS Test and Trace system launched, again to try and pick up any embers of the virus out in the communities. We also had our local infection control fund and adult social care COVID-19 plan published. On the 30th of June, we have our local outbreak control plan published on the council website. So these are all the sort of the next phase of trying to get on top of any small pockets of virus that are still remaining. Could I have the next slide, please? So I just thought it would be useful to share this in terms of looking at the number of lab confirmed cases, and clearly the more we look for the virus, the more we're going to find it. You can see in London we've had approaching 35,000 confirmed lab cases as of today, and that's a rate of 388 people per 100,000. For Kingston, we've had 745 lab confirmed cases, which is a rate of 424.6. If we look in Southwest London, we're ranked fifth out of 6. It's only Richmond that's got a lower rate per 100,000. All the other boroughs in Southwest London have a higher rate per 100,000, but still we're above the average for London. And again, the more we look, the more people are tested, the more likely we are to find it. And on the right, you can just see the curve of all deaths and COVID-19 deaths per 100,000 people for Kingston, and you can see the peak that was occurring in April and into early May, and how much it's flattened as the result of having the lockdown. But clearly it hasn't gone away, and sadly, whilst we don't have many deaths now, they still are occurring occasionally, and we are still picking up people that are positive, but again at very small numbers at the Kingston level. So I will pause there before we go on to the next presentation, if there are any questions in the chat. And clearly we're going to be covering lots of other topics during the meeting. We can come back to any of this if people want to pick it up later.
Yeah,
it's really just to set the scene.
Iona, I haven't got any questions in the chat box at the moment, so happy to go on to the next item.
Lovely. So if we could have the next slide, please. And this is looking at the Children's Services response. So I'd like to hand over to Ian Dodds to just talk through this. Thank you, Ian.
Thanks, Iona. So I have 2 slides. The first one focuses on our immediate response to COVID-19, and then the second slide looks at how we've responded and have begun the recovery journey, so from June. So in terms of our immediate response, our absolute priority was obviously to maintain the safeguarding of children and young people. And at the start of the process, we risk rated all children and young people who are known to us to inform our safeguarding response. So those who are at the highest risk, we continued to visit face-to-face, but the majority of children who were at the lower end of the risk level received virtual visits, and we had good success with virtual visits, and many young people responded really well to them, and we had better engagement with them than we had perhaps had with some of our face-to-face visits, which was very positive. We implemented new operational guidance for our staff so they understood what was required of them, and so that we could retain resilience, particularly as some social workers were not able to be at work. Positively, we maintained service resilience over 80% throughout the initial stages of the lockdown, and it's improved since then. And so we didn't need to implement any contingency plans in order to appropriately safeguard children. We provided additional support to children in care and care leavers, and to those people who were caring for them, such as foster carers and some of our residential care providers. And in particular, many care leavers felt quite isolated from their families and communities, and we have had to put in additional support, particularly around their mental health at the start of the lockdown. And similarly, we've needed to move some of our other services like supervised contact for birth families to virtual contact. And that's worked well for some children, but obviously not for others. It's very difficult, for example, to have virtual contact with a very young baby, for example. And we have focused on contingency planning, particularly given we were anticipating there to be a higher number of children requiring care. That didn't turn out to be the case, but we did recruit additional foster carers from our own workforce in case we needed some contingency care. Schools have been a real important partner with us in safeguarding children, and we supported schools to implement the lockdown. So schools, as you know, were partially closed, and except for those children of critical workers and vulnerable children. And you know, the number of vulnerable children attending schools has increased since the lockdown started, and I'm pleased to say that Kingston has one of the highest levels of vulnerable children attending school in London, and that has helped us with our safeguarding response. There are more children in primary schools than there are in secondary schools, and so we've had to focus on additional ways of engaging young people in the secondary phase. The majority of children, as you know, remained at home, and so we've also supported schools to move their teaching and learning to online environments like Google Classroom. And at the same time, we've had to continue some of the essential education services that we need to provide because they're very time sensitive. So we had to complete the admissions process for both primary and secondary schools during this period as well. And lastly, schools rely on some of the extended activities that happen, and so we have been successful at moving some of those online. So we have a very successful virtual children's centre, for example, and some of our youth work has been delivered very successfully virtually. There's a virtual dance group and a virtual running club, but also where necessary, we've continued some face-to-face contact, particularly doing some detached work in parks and open spaces where groups of young people were gathering during the early stages of the lockdown. And then the last area on this is around our support for children with special educational needs and disabilities. So similarly to our safeguarding response, we completed risk assessments of all of those children with special educational needs coordinators in schools. And for many of those children, we've had to adjust our plans and use the easements to the legislation to make reasonable endeavours for these children, because some of the support that they require could not be delivered during the lockdown. And many children with EHCPs are not at school and therefore are not able to access some of the therapy provision, for example, they receive at school. Although our colleagues have been very successful at moving some of that provision online, and working with parents in order to deliver therapies remotely. We also, as you know, deliver the integrated service for children with disabilities at Moor Lane, and we've been successful at maintaining some of our essential health services, including community nursing. We have struggled, or did struggle at the beginning, with the availability of short break care or respite care for parents, and there was high demand for that. But our provider wasn't working, and so we have had to make alternative arrangements. So the use of some of our facilities at Moor Lane, for example, but also making direct payments to parents so that they're able to sort their own arrangements for respite care for their children. And at the same time, we haven't seen a decline in the number of requests for education, health and care assessments, and that process has continued throughout the lockdown period. So if I move on to the next slide, which is about how we're planning for recovery. So we have now begun the process of reducing the number of virtual visits and increasing the number of face-to-face visits for our child in need, child protection work, and our work with children in care. And so we should be back to all our statutory visits being completed face-to-face by the beginning of August. We are retaining some of the virtual visits where they have worked well, but as an addition to our statutory visiting. And we have restarted some of our suspended services. So from the beginning of July, we commenced supervised contact between children in care and their birth families. We are expecting a spike in referrals. So during the early stages of the lockdown, the number of referrals into children's social care declined significantly, but they are beginning to pick up again. In particular, we're seeing an increase in referrals around domestic violence, for example. But we are planning for an expected peak in referrals from October, when there are more professional eyes on children and young people and they return to school, they start going back into GP and hospital services, and they start rejoining some of their voluntary sector groups. So we are planning for that increase in referrals. Nationally, it's predicted to be somewhere between 20 and 30%, but I think we need to wait and see how that plays out. I think probably what we do know about children's services is that the increase in referrals may go on for a long time, as some of the hidden harm emerges that hasn't been visible during lockdown. In terms of education, we supported schools to open to more pupils in prioritised year groups, so nursery, reception, year 1 and year 6 at the beginning of June, and then to the 2-year groups in secondary school from the middle of June. And we are busy working with them still on their plans for reopening to all pupils in all year groups from September, and also their plans for catch-up learning and their contingency plans for remote learning should there be a local lockdown or indeed a national lockdown. And we do know that many children who will be returning to school will find that quite a challenging experience emotionally, given that they have been away from school for such a long time. And so we are working with schools around a kind of well-being focused curriculum for the start of the new term to make sure that they can settle them back into school and therefore make sure that they're ready for learning, with a particular focus on those pupils who might be emotionally resistant to going back to school, or the group that I've described as happy at home. So those who have really thrived in their learning during a home environment and who might find the transition back to school or the reintegration back to school quite difficult. And we are expecting a significant increase in emotional wellbeing or mental health referrals from September. We are doing some coordination of holiday activity, not specifically focused on catch-up learning for pupils, because I think that is best done when they are back and comfortable in their schools in September, but on some of the wider aspects around learning, so holiday activities, support programs, etc. And then in terms of SEND, we are the legislation that gave us some easements has been withdrawn. So we are back to making best endeavours from September, which is the right thing to do. And we're returning to face-to-face therapies and clinics from the beginning of August. We do expect to see an increase in requests for education, health and care assessments. And so we're planning for that spike as well. And we are now easing back up some of that short break care provision, particularly over the summer holidays, to provide parents and carers with a break which they haven't been able to have while they've been caring for their children with SEND during the lockdown. So I think that's all I wanted to say, but I'm very happy, Councillor Shaper, to answer any questions anyone may have.
Thank you, Ian. I'm just looking at the chat box. I haven't at the moment seen any questions coming through. I'm just going to offer it up to members if you have any questions. Now would be a good time to ask them. If not, then perhaps you might think about later on in the session, perhaps if we have time. But at the moment, I do have one from an unknown. Could I just have your name, please, in the chat box first?
I think it's from Naz.
I do apologise, Naz. Yeah,
that's fine, sir. I put my name at the end. I'm sorry. So the question I got, Ian, do you have any idea during this whole phase whether there have been risks to the implementation of the different elements around social care, education, and SEND? Any risks to the children in those elements? Because, like, sort of obviously as times have been ramping up, there have been some children who have probably not had the same access as they've had previously, and so consequently there may well be harm. There may well have been harm that has come to that child as a consequence of this. And I didn't know whether you had an idea about that.
So I don't have a concrete idea, but I know that there will have been harm to children happening that has been hidden from professional eyes during the lockdown that we haven't seen. And that is why we are predicting an increase in contacts and referrals. And we have begun to see that, if I'm honest with you. So since more pupils went back to school in June, we've seen an increase in referrals from schools. And we've also seen an increase in referrals from the police around domestic violence and abuse. And of course, we are beginning to see some of the tensions around family breakdown coming around as families are struggling to cope with their children at home. And that, I would say, from what I have seen recently, particularly parents who are trying to manage children who have quite complex health needs and disabilities, who are older and more difficult to maintain when they can't get out of the house as much as they previously had done. So I think we're seeing an increase across a number of areas. But what I'm always asked is, what do I think that will look like in terms of numbers? And I don't think I can provide that yet. And I won't really know until October, when I think the spike will hit.
Thanks, Ian. The next question, I believe, is from Diane, Councillor White. Thank you, Diane.
Thank you very much. And my apologies for being late, where I was at corporate parenting panel, where I know Maria and Ian were earlier as well. So I've actually missed Ian's slides. So I just wanted to say at the end, though, that I really do feel that Achieving for Children have supported our children and young people throughout this period extremely well. They have planned very well. They have considered all eventualities. Their communication with families, but also certainly with the voluntary sector and with other partners, and collaboration, I feel, has been really, really strong. So when we look at the lessons, I'm sure we'll find some, but I do think we should say thank you very much to everybody in our schools, in our social care teams. Thank you.
Thank you so much, Diane, Councillor White. Dr. Liz Mirabue, your question is about, could there be more information on the effects on anorexia services? Ian, would you be able to give an update on that?
So I've seen the presenting needs around emotional health services, and I haven't seen that there's been an increase in eating disorders, but I will go back and have a look at that, and I can update the committee or the Health and Wellbeing Board when I've got that detail. But I haven't seen any issues around eating disorders recently. I don't know if that answered Liz's question or not.
Dr. Mirabue, now would be a good chance to respond, if you can.
Yes, I think it'd be great if you could have a look at it, Ian, and then if I've got any further questions, I can come back to you. And I'm sorry that my internet connection keeps dipping in and out tonight, which is why I keep leaving the meeting. It's not intentional.
Thank you so much, Liz. I think if there are no further questions on your item, Ian, if I could then move on to the next item, which I believe is presented by Helen Coombs from our Strategic Commissioning. Helen, are you there?
Good evening, Councillor Shaper. I'm speaking on behalf of Helen Coombs. It's Jane Bierman, Interim Director of Adult Social Care.
Okay, thank you, Jane. Over to you.
Thank you. Can I have the... Thank you. I want to talk this evening about the commissioning of the care market and the resilience plan that we have put in place during the COVID-19 period. The government required us in adult social care to come up with a resilience plan which had 4 aspects, and it covered Pillar 1, which was infection control, Pillar 2, workforce, Pillar 3, supporting independence, life care and responding to individual need, and Pillar 4, which was about supporting local authority and care providers. So what are those elements of those particular pillars? I'll just touch on. And in Pillar 1, which was all regarding infection control and how we could really support the care market to be resilient in terms of their infection control practice. And what we did within this is provide support in terms of ensuring that people had, or organisations had, effective personal protective equipment. We came up with a care market outbreak management plan so that if there was an outbreak within a particular home, we could plan accordingly and have a swift response to their support. We set up test, track and tracing for the care market, and we really focused on hospital discharge arrangements. And I think people are aware that there was some concern about the hospital discharge arrangements of individuals that have been COVID-19 positive and were transferred into the care home environment. And we have worked with the health sector to ensure that those discharges follow best practice. We've also had discussions with the market in terms of responding to increased demand. So that was the infection control areas. Going on then to the workforce. Workforce amongst our care home providers has been absolutely critical in ensuring that they have got the right staff with the right skill set, and that they have a resilience within their group of staff due to the quite a number of staff that were potentially affected by being COVID positive or being in a group that had to be shielded. So in workforce, we discussed with the care market about staffing and ensuring that they had good recruitment processes in place. We talked to them about best practice around well-being of staff, appreciation of staff, and how they could develop their market. Going on then to supporting independence and life care, responding to individual need, we very much have had an integrated approach with our health partners, and we have set up a number of business processes. We have ensured that best practice has been followed in terms of advanced care planning. And we have not just had a focus on older people's services, but really focused on vulnerable groups, such as people who have learning disabilities, mental health, and indeed people that are residing in supported living environments, which I think in terms of the government guidance wasn't given sufficient focus to earlier on. And we have set up a range of quality and monitoring mechanisms to ensure that we've got real-time information about the resilience in our care homes. And we have had also focus on carers, and that encompasses individuals who, sorry, I haven't quite finished that slide, so if you could go back one, please, thank you. As I say, we really focused on carers as well. And in terms of the care homes, we have been discussing with them about best practice in terms of families and how we can support families through this time, bearing in mind that a whole range of families weren't able to see their loved ones during this period. And a range of systems have been set up so that people can remain in contact, for instance, by the use of iPads. So we've really tried to communicate what was best practice. Going on to the last pillar then, which is supporting care providers, we've had a care plan involving funding, which was provided by central government, and funding has been distributed to care homes and home care providers. We've developed a dashboard with our health colleagues, which provides us with a great deal of intelligence, which is gained from a range of different sources, to really provide an insight into any concerns that we might have with a particular provider. So it helps us target our intervention and approach. As I say, we've very much provided in this response an integrated approach with our health colleagues, and we've had regular meetings with them both at a strategic level and an operational level to ensure that we have wraparound support to the care home market. So I think that's all. Thank you, Chair. Very happy to answer any questions.
Sorry, I was on mute. First question comes from Councillor Rowena Bass. Rowena, over to you.
Thank you, Chair. Yeah, no, I just wondered if I could ask a little bit about the hospital transfers. So I've had a lot of, I just wanted to work out what did happen during the lockdown, because I don't know whether, I've just had anecdotal stuff from residents saying that someone they knew was tested but then moved into a care home but didn't get the results until after they were in the care home and they were positive. I don't know how true that was. But also I understand from when I sat in on a governor's call at the hospital that they were using Teddington Memorial. So I think I was getting probably a lot of truths, untruths. I just wondered what the situation was about moving from a hospital to care home then. And then going on from that, what is the protocol now? Because obviously we've learned from what happened.
Thank you, Councillor Bass. I know that my colleagues from your healthcare are on the call, and they may well be best placed to answer the responses around the hospital discharge response. But I do know that in terms of people that were identified as being COVID-19 positive in the hospital setting, they were transferred, if they were Kingston residents, into Teddington Memorial. And indeed, I understand there were some patients discharged into New Victoria as well. But I understand that people who were COVID positive were discharged to a ward at Teddington. But other patients, if they were Kingston residents who are non-COVID, could have been discharged to the New Vic, which was commissioned in light of the pandemic to provide extra resources and extra capacity. The protocol, I think it's fair to say that, as we know nationally, the protocol in terms of hospital discharge and testing did evolve, but we haven't been able to identify any concerns locally in terms of inappropriate discharges into care homes where people were COVID positive. As aware as I am in terms of the knowledge base we have locally, I think that it was effectively managed, and we worked with our colleagues to identify people that were COVID-19 in the acute hospital and how they were transferred appropriately into other settings that were best placed to facilitate appropriate discharges and could also respond appropriately to somebody who was COVID-19 positive. So I'm not aware of people being transferred immediately into a care home environment, but it may well be that Ed Montgomery or Grant Henderson from your healthcare may well want to add some additional information.
Thank you, Jane. What I'd like to do is, I've just got one question from Councillor Ryder Mills. Before we get Dave, you can ask your question. Perhaps I can just hand that pause for a second, just to see if Ed, you wanted just to come in on that point that Jane was mentioning.
It's Grant, actually. I don't mind taking.
Oh, Grant, apologies.
Yes, fine. We did indeed have an arrangement whereby we split the two wards at Teddington Memorial into a, if you like, a hot and cold arrangement for wards. I think it's fair to say in the beginning, asymptomatic patients from hospital may have been discharged to any care setting, whereas now that's been replaced by testing of those individuals before those transfers were made. But even in the earliest of stages, when somebody was transferred to any environment in the absence of or the presumption of them being in any way susceptible to have been COVID-19, there were plans in place to ensure that people were nursed in isolation prior to them being free from that sort of quarantine period. Now that's subsequently been substituted for the more rigorous testing, so nobody actually even leaves the hospital positive for COVID-19 unless they're going into a positive COVID-19 suitable environment.
Thank you, Grant.
Anita, could I just follow up on that?
You can. I do have a question though that I'm just going to see if Councillor Ryder Mills is going to sort out some technical issues he has. But if you want to quickly come back on that and then see if that gives Councillor Ryder Mills a minute or two to sort
okay,
out
it was just
thanks.
Yeah, mine's not brilliant tonight either.
So, Rowena, if you can come in now, that'd be good.
I think the case that was put to me was that someone knew someone that was tested in hospital, but the result didn't come through until after they were placed in the care home. And I just wanted reassurance that wouldn't have been the case. And just to clarify, so in the early days, there were people who were transferred into care homes that were asymptomatic and not tested.
You want me to come in? It's Sally at the hospital.
Yeah, thanks, Sally. Yeah.
Okay. So the new guidance, I think, was published on the 19th of March. And since then, both Ed and Jane have given exactly the account that was my experience here at the hospital. So no one went from the hospital positive, apart from to Teddington Memorial or to the New Vic. So that's absolutely right. Ahead of that, when there was no requirement to test patients, it may have been that they did go asymptomatically into a care home, but we have seen no evidence of that. I've had no feedback, no incident forms, nothing at all. And I expect that would have been the case. If, you know, some of those patients may well have never tested positive, but been asymptomatic. So 80% of the population have had COVID without having any symptoms. But no, following the guidance, nobody left here who was positive and went back to a care home.
Thank you very much for that, Valerie.
Thank you, Chair. Thank you. Sorry for probing that, but it's just been quite sort of topical, but that's really reassuring. Thank you.
Thank you very much. I think the question from Councillor Ryder-Mills, unless you've got your mute situation sorted out, or unmute, but the question is obviously about the PPE supply. How big a problem was it this, and how and are there now good stockpiles is the question. Jane, can you come in on that question?
Yes, Chair, I can answer. And again, it may well be colleagues may well wish to respond as well. I perceive in the early days, I think there was quite a lot of concern around being able to access PPE equipment in a timely fashion. And we put in place, as it says in our infection control plan, a system whereby if a provider felt they were going to run out of any type of PPE equipment within 3 days, then we would supply them with a stock from our local authority supply. So quite early on, the local authority received PPE equipment and have been utilising that in quite a strict criteria basis. We have absolutely managed to source good supply, and we have had now sufficient supply of all types of PPE equipment for some time. So we're not aware of any provider locally that ran out of PPE equipment. And also I understand that on one occasion we in fact helped the hospital out in terms of a particular type of equipment. So it was challenging at the beginning, and I think that there was obviously an enormous call on suppliers to not only provide health but also all types of settings, and therefore the supply initially was very hard to get a hold of, and now the supply chain to providers directly and to the local authority seems to have evened out and seems to be much more resilient.
Thank you, Jane, for that. So if I can just go on to the next question, David Still, if you would like to ask your question, thank you. David, can you try and unmute if you can to ask your question? I think David may be having a issue with his technical issue there. Can you all hear me? That's the main thing, that I'm not having any technical issues my end.
Yeah, we can hear you clearly.
Okay, so I think David, if you can hear us, there you are. So over to you, David, if you can ask your question. Thank you. I think there still may be some technical issues there. Perhaps what I might do is come back to David. David, we can't hear you at the moment. So what I'm suggesting is if you come out of your of the briefing session and go back in again, that might help. Otherwise, we'll be able to come back to you, because I believe, Jane, you're presenting the next item, aren't you, on the discharge planning?
I'm presenting it. I think Grant and Ed are going to do the initial part of the hospital discharge plan, and then I've got a number of slides after that. So I'm going to take over from the point where I'm going to describe the government guidance. Thank you, Chair.
Okay, Jane. So I think Grant, if
yeah, that's
what I'll do is, I think, David, if you write your question in the chat, and then we'll try and come back to you. But Grant, over to you.
Okay, so the focus was predominantly and almost immediately on really stimulating rapid discharge process from our local acute hospital in particular, with the predicted requirement for a large number of acute beds. So community insisted, we moved really swiftly to prioritise the roles within our community services, reflecting the guidance that was released to prioritise those, and we increased as much capacity as we could into those roles which support the capacity or ability to discharge. There was a daily interaction with the Joint Assessment and Discharge team, and this was even extended during the early periods of the outbreak to extended out to our primary care colleagues, and we had a number of even the PCN directors joining those calls to try and facilitate discharges from patients they knew well within the hospital, who they could be able to facilitate their discharge home. And even if they weren't their own patients, they were happy to liaise with other primary care colleagues to facilitate those discharges rapidly on their behalf. We also had some very stringent guidance coming round and suggesting the adoption of the discharge to assess guidance and processes immediately, and we rapidly implemented those, introduced following the lines within the community's standard operating procedure, extending our business open hours from 8 till 8, and they extended up for 7 days a week as well. And that presents quite a dramatic alteration. We'd had some early success with discharge to assess, but not really in this number, and certainly not over those opening hours of the week. So that was a real step change in terms of the focus. It's predominantly around assessing to discharge, really, but really we need to move to this discharge to assess, where the majority of the assessment actually take place in somebody's home once they've been safely discharged. So to support that, we also had to increase some of those services that sit around that discharge to assess model, things like the availability of same-day equipment. Rapidly, within a couple of hours, we could get equipment in. We were able to create sort of micro-environments within people's homes using things like the handyman service and partners at Staywell. And also we were fortunate enough to have an additional supply of actual community beds. There was an additional 19 beds commissioned at the New Victoria Hospital to promote flow. So nobody stayed in the acute longer than they needed to. And with those beds, we were quite flexible about our arrangements in terms of the criteria that would normally sit around those beds. So we took in people who needed somewhere safe to go, irrespective of whether it was a health or a social care delay. They were just simply taken into those beds, and that was the next stage in that person's pathway to enable them to flow promptly out of the hospital. If I could have the next slide, please. So clearly, as health, we all work together collaboratively with the Response Coordination Centre, supporting the health needs of those who couldn't really leave home, including the vulnerable, the self-isolated, and obviously those who have been shielding. With partners, Your Health Community, we maintained as many frontline visiting services as we could. So clearly, an awful lot of our services, community nursing and so on, don't readily lend themselves to video conferencing and other things. We've used that quite effectively where we can, but sometimes a visit is what's required, and we've maintained those throughout in terms of community nursing, our urgent care response teams, things like the rapid response team, our care home support team. We were able to field our dementia nurse into supporting families who in other circumstances might have been perhaps attending for daycare and other services which weren't necessarily available at the same extent as they might have been outside of the outbreak. And we've been using some of our skilled staff who were commissioned to provide what they call a high intensity user service for those people frequently presenting at the hospital. They've got a particularly good skill set in regard to engaging with people in a sort of a community outreach type approach, and so they were busily out in the field too, looking after those individuals with really quite complex arrangements. Again, they were quite vulnerable during this time, and clearly there was an enormous focus on supporting our care home support teams, supplying urgent visits, education, training, PPE and advice, alongside infection control and testing. And finally, if I could have the next slide, please. So we provided a wellbeing service for those with complex needs, especially some of those lower mental health kind of wellbeing issues. We delivered wellbeing packs and personalised gift boxes to some of those individuals I've mentioned previously and identified. We also introduced and provided sort of virtual FaceTime type contacts for those not able to receive visitors, particularly from our inpatient settings and in some of the care homes. And this included even providing end-of-life care with some where family members were quite remote and couldn't travel to visit those at the last stages of their life. We had some quite enterprising ways of connecting people so that they were able to deliver that kind of really premium kind of end-of-life care, really. And then the introduction of the large-scale testing prior to individual either receipt into one of our establishments, as we've mentioned earlier, or their onward transfer into any other care setting, be that domiciliary care or into a care home as such. And then that widespread testing has continued amongst all of our frontline teams. They're regularly tested now every 14 days, so any of our teams going out into individuals. If I could have the next slide, please. I think this is, did you want to pick this one up, Jane?
Yeah, thank you, Grant. Thank you, Grant, for that. Just to go on then, in terms of hospital discharge.
Oh, I do apologise, Jane. Can I just quickly just mention that David still had a question that I didn't know whether this was one for Grant or one that you could answer about the ongoing position for PPE for carers. I just wanted to make sure that he got his question in. Is that something that you could answer?
If it's in respect of carers of people with direct payments, I am very aware that carers who are going into, who are personal assistants, meeting the needs of people who are receiving a direct payment, are being supplied with PPE as well. I don't know if that was what was meant by the question, because obviously the word carer means a number of things. So yeah. Quite sure the context of the question, Chair.
I think what I'll do, Jane, is if you carry on with your slide, and then if David, you can put it in the chat box just to clarify, we'll see if we can bring that in. Because I'm obviously conscious that after you've spoken, Jane, I think I'm going to bring Vanessa Ford in to do her slide. So I think if we just keep to the current slide that you have on the screen, Jane, and then David, if you can just put in the chat box that point of clarification, I think that will help. So if you carry on, Jane, that will be good. Thank you.
Fine, thank you, Chair. So in terms of just expanding on Grant's approach in terms of your healthcare situation, so we received government guidance which set out quite an inordinate range of discharge pathways that we had to set up and follow in a very quick manner. And the discharge process and the assessment model meant that there were 4 pathways. The first pathway, about 50% of people went down that pathway. And really that was a simple discharge and no real input was required from health or social care. Pathway 1 was 45% of people would pass along this pathway and they would need a bit of support within their home setting. Pathway 2, only 4% of people would go down this pathway and they would require some sort of rehabilitation in a bedded setting. And lastly, pathway 3, the government described that about 1% of people would end up having a life-changing event, which meant that home was no longer, sadly, an option for them. And the timescale that was set by central government was a very challenging one. And it meant that we were asked to discharge people when they were fit for discharge in a matter of 1 to 3 hours. And as Grant alluded to, we were asked to set up a service from 8 to 8, 7 days a week. And I have to say that through the collaboration and the galvanising of a wide system support, this was put in place very swiftly. And if we move on to slide 2, I'll just explain what we did. Thank you. So across a partnership between the Royal Borough of Kingston, Your Healthcare, the London Borough of Richmond, Kingston Hospital and HRCH, which is the equivalent health provider, community health provider in Richmond, there was a standard operating procedure set up which really designated what pathways would be with the responsibility of which organisation. I won't go into detail there, but it sets out, according to the 4 pathways that I've just described, which pathways every each organisation would lead on. And we did also set up a pathway in terms of people that were homeless. So go on to the next slide, please. So what I want to touch on now is in terms of our whole system response, and I said what I describe as a real significant challenge is setting up quite a complicated system, a new pathways, a 7-day service based on 8 to 8, and discharging within 2 to 3 hours was a real challenge. But I think that in terms of our partnership working, it was quite a success. And these are the areas that I wanted to just pull out in terms of the areas of success that we've identified. We had regular collaboration workshops with partners, which really strengthened our joint working arrangements. We agreed all our system discharge to assess processes, and also created a new referral form, which really did aid the process and safe discharge planning. We streamlined our referral process and reablement offer. We integrated a range of processes and occupational therapy and allocation discussions. And in terms of people, you know, I have to say, I don't like this term super stranded patients particularly, but that's a sort of a health speak. And it is about people that are quite challenging in terms of being able to discharge them into an onward setting in a safe way. And that we did. And we had real successes in decreasing the numbers of people that were described as super stranded, and then aiding the acute hospital in terms of being able to release beds for people that needed to be admitted. We introduced introduction of a triage and testing prior to any admission on outpatient attendance, discharge and onward transfer. That's what we touched on earlier on in a question that was posed. And we continue to use digital technology to support our virtual consultation processes. We increased the support, training and education in terms of nursing care, and particularly in reaching into our learning disability care homes that, as I mentioned earlier, have had quite a significant challenge due to the complexities of the people that they support. Next slide, please. So in terms of our challenges and the demands going forward, we know that people with COVID-19 have been extremely unwell, and therefore the discharges home have been much lower, unfortunately, due to their acuity. And we are sort of we have to look at quite a number of a range of step down or ways of ensuring that they could move on to further settings rather than being discharged home for the time being. So that was, you know, I think a challenge in that we had to create quite a number of extra capacity in order to accommodate those people's needs at that particular point in their journey. We also have had to do quite a lot of quite urgent workforce planning to meet with the sudden demands and the surge of activity. But I think we've been relatively confident that we've been able to restore a resilient workforce in a range of different settings across the acute provider, community health providers, and indeed in adult social care. We've looked at the performance measures in terms of measuring success, and quite a number of performance measures were changed during the pandemic. The most known performance measure is the the discharge figures in terms of timely discharge. They were put on hold during the pandemic. So we have not currently have our DTOC figures to ensure that we've got timely discharges, but the timescales have obviously shifted, and we have new timescales that we've been monitoring and ensuring particularly that we have monitored our stranded and super stranded patients. And I have to say that I think that we rose to the challenge of facilitating timely discharges and safe discharges, most importantly. And the challenge ahead, I think, is thinking about what's next in terms of our integrated discharge model. I think the pandemic has allowed us to think about how we come together across partners to facilitate discharge. And I think there is a great deal of learning that we've had from that. And we had a joint assessment and discharge team in place prior to the pandemic. And I think that there is an ambition by all partners to build the joint assessment and discharge team and think about what the elements are of the pandemic learning that we can take to really move forward with that model. And lastly, we want to maintain levels of good support for our care homes. We've had a range of wraparound services that have reached into care homes, from primary care to your health care to adult social care. And we need to ensure that that support is resilient and moves into the future in terms of supporting care homes and other providers with their ongoing challenge. Thank you, Chair.
Thank you very much, Jane. I think that actually was one of the questions I put in the chat box about the discharge model and the elements of care. So thank you very much for that presentation. I think if there are no, I have 3 questions from David still. David, if you could try and be as succinct as possible, because I'm mindful that one of the presenters, Vanessa, would like to present her slides prior to 1945. So if you can be as brief as you possibly can, I'd appreciate it. Thank you. I think, David, if you don't mind, because we're on a bit of a tight timeline here, what I'd like to do is I've captured your question, and I'm going to let Vanessa present her item, and then I'm going to bring your question back in, if you don't mind. Thank you very much. As I appreciate, Vanessa, you have to dash off, so if you'd like to present now, thank you.
That's okay. Thank you very much. And I'm sorry for having to move things around. I would normally be able to stay, but unfortunately, I'm not able to this evening. I'm hoping that people can see me, but if not, we'll just keep going. So one of the things that really delights me about the work that we've done during this most difficult time is the fact that already during other people's, oh, wait a minute. Is my mic not working?
We can hear you, Vanessa. No, it's fine.
Oh, you can. Oh, sorry.
Yes,
okay, great. One of the things that's delighted me is that actually during other people's presentations, everybody's mentioned mental health. And during COVID, we have continued to provide all of the mental health services. except for the memory assessment services, because it wasn't possible to provide those and support people in the older age bracket to Shield. So it would have been an issue. But we have provided services in new ways. So we moved a large proportion of our services onto digital platforms. We've done some early feedback and responses from patients about their experience of digital platforms. A lot of people have preferred it. Some people have not. And we are now moving our services back to being able to offer people a choice between digital and face-to-face. Our most at-risk patients, we continue to see face-to-face throughout the crisis, both in the community, and our inpatient services have continued. We have run and set up a new mental health emergency department, which is open to patients from all of the 5 boroughs that we serve, and is based in Springfield. And we've supported people with transport and the way to get there. We've also strengthened our mental health crisis support line and expanded our home treatment team, so those people in crisis can get that support. That said, I think we need to be really, really clear that COVID-19 and the isolation that people have felt through self-isolation and the stress of potentially being isolated with people that you may not choose to spend all your time with has been really significant. And the impact for mental health and the surge for mental health is yet to come. We saw during COVID that the demand for our services dropped, and we were able to work to support people as best we can. However, we are now seeing that we have returned to pre-COVID levels, and we are seeing an upward surge, particularly for those people who were left in vulnerable positions during the outbreak. Now, these may have been individuals who were previously known to mental health services but discharged well to their GPs, but during this period have had a relapse and weren't able to access support, partly because they didn't know how to ask for it, perhaps they weren't referred. So we're really doing a big piece of work increasing people's ability to refer to us. I'm able to talk about this at length, but I suppose I want to make sure that people can ask me any questions or queries in connection to the mental health provision during this time.
Thank you very much, Vanessa. I can't see any questions specifically in the chat box at the moment, but what I'm going to do is just, I know you've got to dash off. If anyone does come up with any mental health questions later on, I'm going to make a note of them, and then perhaps if we can just have a chat offline. Absolutely. And then see if maybe you'll be able to respond that way by email. Might be quickest and easiest way.
Absolutely, I'll be delighted to. The other thing I just wanted to flag, which I should have flagged at the beginning, yesterday we had a COVID-19 mental health crisis summit. It was Mental Health Promotion Crisis Summit. We had 300 members of the community from all different backgrounds join that summit. So thank you to those of you who were on this call who supported us, and we really look forward to taking forward the outputs from that summit. And thank you for coming.
Thank you very much.
Thank you.
Yeah, thank you, Vanessa. I know you have to dash off, so
yes, thank you.
Thank you. I just wanted to thank you, Vanessa. Just before we go on to the next presenter, I just wanted to capture from the previous item a message from David Steele. And I think what I'm going to do is I'm just going to read out what he's written in the chat box. He's just saying, this was to do with the PPE and the carers. He was just saying, also an issue has been raised by one of our carers who wants to enter the care home where her mother is resident to provide care for her, but is prevented from doing so unless she can be regarded as having the status of a key worker. I don't know if that's a question that anyone can answer now, or whether it's more appropriate that you might be able to come back to, David, after this session. Very happy for you to let me know. I don't know if that's one for you, Jane, or one for you, Grant. Perhaps you could just let me know.
I can answer very briefly, Chair. I would say that most care homes have had to sadly make the decision to restrict access to the care home of families and relatives in order to protect the safeguarding of all the residents. This is an infection control measure. So each home have brought into action infection control guidance. So it will be up to the individual home to describe and see what's most appropriate in terms of the context of that home. I know that some homes have tried to facilitate families being able to visit, but they're doing that with very clear guidance in terms of best practice, and it will depend on the environment they have as to how assured they are in doing that safely. But they have a responsibility to make sure that the residents are safe and also the staff are safe. And so that will be their main reason maybe for not suggesting that families can come on the premises at this time. But I understand that a lot of homes are waiting government guidance about how to open up homes to relatives and friends. But that will take some time, I think, to come into play. Because they will no doubt have to make a great deal of preparation before that takes place.
Thank you, Jane. I'm just capturing one last set of comments from David Still. I'm just going to read them out. It's just really, we may have covered them already, so bear with me. One of them is about whether day centres are going to be opened. I think the question is when, or if, not if, sorry, when. I think he just wanted to have an idea about timing. Also about, I think we've talked about PPE for carers. I've got here brackets unpaid. I'm not quite sure what that means exactly, but maybe somebody might be able to be better at answering that one. But also I think the final one is a carer being a key worker. I think his comment is just that there's a need to lobby government on that point. But if there's any aspect of those items that you might be able to just come back with quickly now. So one is about the day centres being opened, PPE for carers, brackets unpaid, question mark. And I think the other one, it was more a general comment about carer being a key worker, need to lobby government. But on any of those issues, do you have anything further you can add, Jane?
I could just add on the day centres, Chair. I think maybe if I can respond to the other questions outside the meeting, because I probably need to understand a little bit more of their context. That would be
I'll put you both in touch with each other after the meeting, I think.
Absolutely, yeah. I'm very happy to do that. So in terms of the day centres and the opening, obviously the day centres are mainly provided by voluntary sector organisations in the borough. And I understand that each individual provider are looking at plans to reopen, but that will the timing of that opening will be up to them as providers of services. And as I said, in relation to care homes, I think all of the providers are taking very careful steps in ensuring that we're balancing the needs of the communities that have been isolated for some time. And as we know, carers no doubt will need a break, and also other residents that would like to come back to those settings. But I think that we have to do that in the context of ensuring that it's a safe environment to return to, and that we've got good infection control measures in place. So the timing of that opening will really depend on all those processes being in place, and that also will depend on the actual provider feeling that they're ready to do so.
Thank you, Jane. And the very last question, I think I'm going to have to then go on to the next slide, is from Dr. Liz Muirview. Is the deterioration in care home residents with dementia being monitored? And I think that will be the last question I can bring at the moment. Would you be able to answer that one, Jane? Or is that something that you might be able to send, have an email or something that you can discuss with Dr. Muirview after the meeting, after the seminar?
Yes, I'm very happy to do so, Chair. I'm not aware of the impact of the pandemic creating a deterioration in people with dementia. Obviously, sadly, there is a natural deterioration with people with dementia. I think that there is, again, as we touched on in terms of people's emotional well-being, will have an impact. and you know, the fact that people with dementia will have often been in a situation where they've had to be socially isolated in their rooms for some time. So those will have an impact. But I think in terms of an evidence base, I'm not aware of that, but I'm very happy to hear if other people have information that we should learn from. So yes, I'm happy
Chair, could I just come in here as to why I was asking that question?
Very briefly, Liz, if you can, I'd appreciate it. It
was nationally that societies such as the Alzheimer's Society have been finding that people who have dementia, of course, often simply don't understand why they're not being visited and cannot be helped to understand it, and the risk of people's mental health and cognitive health deteriorating because they simply do not understand where their families have gone.
I think, Chair, just to say lastly on that question, I think most homes are working extremely hard. I know from having contact with the registered manager, Amy Woodgate, which is a residential home for people with dementia. I think within the restrictions of the environment we're in and the pandemic, I think that care home staff have tried all sorts of ways of maintaining contact with families. And I know from Amy Woodgate, for example, they have a plan for each individual resident about how they can maintain contact. I know that's not perfect, and I'm sure that the care homes are struggling, you know, to maintain contact and you know, ensure that the individual understands what's happening to them. But I think this is very challenging times. But I've heard a lot of very innovative practice from care homes about how they're doing their best to maintain the well-being of their residents.
Thank you, Jane, very much for that. It was probably the way I read out the questions earlier for David, but I just wanted to clarify on one point. It's actually, this is from Councillor Diane White, it's actually, just to add, it's carers, not as well as care workers, i.e. family members and friends may need PPE too. So it may have been the way I read out a question earlier, but I just wanted to clarify that point. And if there's any further points of clarification, please put them in the chat box for me. But I think, thank you very much, Jane. Thank you, Grant, for those items. And Vanessa, I know she's gone, but I'm going to move now on. If there's no further questions, can I move on to
Anita,
yes,
I put in the chat box, I had a question. Is that all right?
Oh, okay. I do apologise. Can you be as brief as possible so I can go on? Thank you. And then we'll go on to the next item. Thank you, Councillor Bass. Your question, please.
I apologise if you had covered. I've had a bit of internet problem, but I don't think it was covered. So my one, well, I had one question, and that was one thing that's in the news is people, care agency workers working between care homes. I just wanted to make sure we had a protocol to stop that happening. So that's a question to the officers. And then Anita, well, maybe it's a question for you or for the officers. I mean, I think it's really good that we're having a discussion about this in public, but I just wonder how the public would know about it because it's not on the Kingston meetings calendar. So I wondered how it was advertised.
Can I come back to you on that one, Councillor Bass, on how it's advertised? I'll see if I can get through to the ICT team. I'll come back to you on that point. But let me just, because I know timing is tight, let me just see if Jane, you might be able to come back on the point about the protocol.
Yeah,
if you don't mind.
Thanks, Anita. It's just there are only 10 members of the public on there, and it wasn't on the meetings calendar.
I will absolutely follow that up for you. Thank you very much. It is a learning process as well, but I will follow that up. So Jane, if you could just come back on the protocol, thanks.
Thank you, Chair. In terms of the support plan that I mentioned earlier in the presentation, this is an element around the workforce pillar, and what we've been giving advice to our care home providers locally through regular forums with them is about best practice. We cannot demand, we cannot say they must do things. We can only suggest and point to them the best practice. And we have certainly raised this with them, as it is in terms of the infection control plan for care homes. It absolutely is, as Councillor Bass has alluded to. It's a real key issue, is that care homes should not be employing individuals who move from one care home or any care home setting to another, and therefore increase the risk of the transmission of the COVID-19. So we have given advice. We have had regular forums of which to raise best practice, and this is an element of best practice. So we have suggested to them that they need to follow government guidelines and, as best they can, ensure that workforce is contained to a singular care provider.
Thank you very much.
And I've just heard on the chat, and this won't be, the public don't hear the chat, so apparently it was advertised on the social media, but I think we have to bear in mind that not everyone's on social media, so unless it goes on the notice boards or on the calendar, then a lot of people are going to miss it. That's probably why there are only 9. So I think that's a shame.
I was actually, he beat me to it, Councillor Bass. I was actually going to email you to say, send me through your question in full, and I'll see if I can follow it up after the seminar this evening. But just so I wanted to capture what you were saying, to make sure that I could deal with it after the seminar. So by all means, ping me over an email after this seminar, just to reiterate what you were just saying. I'd find that very helpful. I'd like to now, if you don't mind, everybody, move on to the next item. If there's no further questions, I'm just looking at the time, making sure we can stick to a tight time schedule. So Dr. Andrew Cross, I believe, is the next item, Kingston Stronger Together. Over to you, Andy.
Thank you, Chair. So until now, we've been talking about support the health and care sector have been providing. I'm here to talk about what Kingston Stronger Together have been doing to support the whole community in partnership with those formal providers. So, and I should say that I'm presenting it on behalf of not just the council officers involved, but Voluntary in Kingston Voluntary Actor, and the broader community voluntary and community sector organisations that have been involved in this work. And of course, most people that have been able to support themselves through this difficult time with the support of their own family, friends and neighbours, and indeed community organisations stepping up to support each other without the need for us to be involved. But for those that have needed additional support, the Kingston Stronger Together Support Hub has been running, offering information on COVID-19 and staying healthy and well through this time, both physically and mentally. Help to get essential supplies delivered for those that couldn't leave their homes and still can't leave their homes because they may have symptoms of COVID or have been in contact with some positive case. We've been providing emotional and social support and referral on to, I've said, existing health and care services. Of course, that also we've been referring into those new groups that have been set up around mental health. Vanessa was talking about high intensity users. I think Grant was talking about, and social care services that Ian and Jane were talking about. And the way to access the hub, the referral routes in are on the screen and have been there for some time. So I'll move on to the next slide, please. Just talking about the activity the hub has seen. So one of the key groups we've been working with is the extremely clinically vulnerable group, those on the shielding lists. In Kingston, there are 5,935, and we've contacted all of those through the hub, proactively offering support. And the number that have needed help is about 9%, so 540. And in total, the support hub has received 2,762 support from requests for support from people in the community. These slides have been circulated, so I won't go through all of these numbers, but just to say that in terms of the referrals into those health and care services, those up at higher level services, there have been 79, but I would say that we have been getting advice from social care professionals in managing a lot of the cases that have been picked up ultimately by the voluntary community sector and deployed RBK staff from non-social care services. And we've also deployed 174 resident volunteers within directly through the hub, but of course many more volunteers have been utilised by those voluntary sector partners who are working in response to the COVID pandemic, but also were working before that in different ways. So if we go to the next slide, please. I thought that just it was an interesting, just to give you this, the map on the left is our heat map of where those support requests have come from. And given the focus on both the Health and Wellbeing Board and the Health Overview Panel on addressing health inequalities, that actually the support requests map very closely to areas of deprivation in Kingston, and not as we might have predicted around sort of older age groups, and really showing that the burden of the difficult time everyone has faced, potentially the needs coming out are as much around deprivation and the difficulties people are facing through financial difficulties as much as through being in older age groups and more vulnerable groups, so clinically vulnerable groups. So if we go to the next slide, please. I know we're short on time. So just to say, in terms of the next steps, we are stopping the proactive calls to the people in the extremely clinically vulnerable group at the end of July, in line with pausing of the shielding programme. That's got an asterisk because we are still continuing some of the proactive calls we are doing, supporting hospital discharge. So we've been contacting people, as Jane mentioned, there's 50% of people who leave hospital without a formal package of care or support from formal social care services, but we have been following up with those to offer support from the community sector through the hub, and we're in discussions with Jane's team around how if we continue those to support hospital discharge and safe hospital discharge, and the reactive support will continue for those that need it beyond July. As I mentioned, there are still people that at short notice may have to go into self-isolation because they've been in contact with someone who's been confirmed to have COVID, or because they have symptoms of COVID themselves. And also, we're keen to continue to support those who are vulnerable in the community. And just to say that we are reviewing the kind of whole experience of working in the way that we have through the hub with FutureGov. We're leading an external review to look at what we can learn from this experience, what we may like to continue from the hub, and how what we're offering needs to evolve, because those support needs are changing, and we are seeing, as others have mentioned, particularly health needs, but also financial support needs being more of an issue, whereas before we maybe focused more on emergency food supplies and things like that. So we are feeding into the broader transformational objectives that all partners will be aware of, both in the council and outside. And happy to take any questions.
Thank you very much, Andrew. I have Diane with a question, and then Maria after her, and then followed by Emily Davey, Councillor Davey. So I'll start off with you, Diane. Thank you.
Thank you very much. I think I'm sort of linking this with the next item, which is the voluntary sector community. And I appreciate this is about the hub, and it's really amazing statistics that you have, and the support that's been offered. But it is sort of, this is the hub, and then we have the voluntary sector offer. And in one sense, I'd really like to see it all combined, in particular something, for example, the food parcels, because I know there's been a lot of food parcels delivered by the hub, but then you've got DLAG and you've got all the different voluntary sector organisations who have been delivering their own service users. So I just wondered if we might be able to bring all that together. And just to say, I really liked the map. Thank you very much. That was really, really interesting.
Thank you. And yes, within the review we're doing, we're looking at how we bring in broader voluntary and community sector partners, and also on top of that, how we link. This is all set up very quickly, as the other services were, and potentially there's more we can do with the primary care networks, children's services, particularly, as I mentioned, adult social care have been heavily involved, and maybe kind of linking in with other broader community sector partners, as you mentioned. Yes.
Thank you, Andrew. The next question is Maria, please, over to you. Councillor Netley, I should say. If Councillor Netley, you could ask your question, thank you.
Sorry, I had my internal microphone on mute as well. Yeah, we've had a lot of talk about the volunteers and the way that they've been deployed, but in the early stages, the numbers that we were quoted in terms of the people who'd actually volunteered through the hub was in the high hundreds. Yet we see the figures here that there's only 174 who have actually been deployed, and also the buddies allocated 194 versus 174. Is that because people have been you have volunteers who have been allocated more than one buddy? Thank you, Chair.
Thank you, Councillor Netley. Andrew, if you could answer that one, that'd be lovely. Thanks.
Yes. So that number of deployed volunteers is the number that we've deployed directly through the hub and linked up with voluntary sector partners and directly through the services the hub are providing. There are more volunteers who voluntary sector organisations may have recruited themselves. The numbers you mentioned about the total number of volunteers that came forward, they are higher, and we haven't used all of them. I don't think that's uncommon in an emergency response situation. But what we have done is met demand throughout by use of those volunteers and the deployed staff. So yes, some of the volunteers some of the buddies may have more than one person. Also, some of people who have been given a buddy may be a member of staff. So that befriending service has turned into a lot more than sort of a check-in and chat for people who are at risk of becoming social isolated. They are picking up some people with higher mental health needs as well. And for some of those, we've allocated them a member of staff who's maybe had more training in mental health support or experience with it, or a volunteer who, we've got volunteers from the Samaritans and other people who may have more experience around mental health. So we've tried to link people up as best as we can with the most appropriate level of support when we recognise that it's not just a simple "how are you doing" type chat, that there are complex issues that people may need more support with.
Thank you very much, Andrew. I'm noting that we've got a strict timeline. So Emily, if yours could be the last question, Councillor Davey, thank you.
My question is, I saw in Berrylands and in Norbiton you had a high demand. I just want to know, is it able to be pinpointed or closer to? Are we talking? Is that demand really centering around the Alpha Road Estate, Cambridge Gardens, and Cambridge Road Estates? Is it our own social housing that we're finding that demand, or is it wider spread than that?
I'm afraid I don't have that information. We haven't done the breakdown by housing provider, although what we have done, as well as the proactive calls to the people on extremely clinically vulnerable groups, the housing team did contact people proactively as well and offered them this offer to people who they are in contact with and they identified as more vulnerable. So people who are in touch with housing services may have been proactively contacted more than the general public that aren't in extremely clinically vulnerable groups. So we recognise that the vulnerability is about more than vulnerability to COVID, that this is a difficult time for everyone, and it's not just the COVID things that we're supporting.
Thank you, Andrew. I just wonder, perhaps, Councillor Davey, if there are any further questions you might like to come back with. Perhaps I can sort of facilitate that after the seminar. Dr. Cross, if you might like to come back with any further detail if appropriate. Would that be all right with you, Councillor Davey, if we do it that way?
Thank you.
Fine, thank you.
Yeah, thank you very much. Thank you very much, Dr. Cross. That was very helpful. If there are no further questions, I just wanted to let you all know that as we're slightly running over schedule, we can extend this hangout till 9 p.m. because I'm conscious that we're just under halfway, and we obviously want to include all the items tonight. So I will be a little bit stricter with the number of questions. I am conscious that we do need to get through the agenda, so I'll do my best to get your questions in. But if I can then move on to the next item. So if everyone is agreeable, I will be extending the hangout session till 9 p.m. this evening. For those who are listening in, members of the public, we are able to extend till 9 p.m. if everybody is happy with that. If you do have to dash off, let me know in the chat box, and I'll see if I can rearrange the presentation items. But if not, then we'll move on. So if we can move on to the next, so thank you, Dr. Cross. If we can move on to the next item, which is Sanja Cheric, if I pronounced your name correctly. Thank you, over to you.
Hi, can everyone hear me?
Yes, loud and clear, thanks.
That's great. It's Sanja.
Sorry, what did I say?
Sanja, which I
all right, thank you. I apologise,
okay,
thank you.
That's okay, don't worry. So I'm Sanja Cheric, I'm the CEO of Kingston Voluntary Action. And next slide, please. Right, so Kingston Voluntary Action as the main infrastructure organisation in the borough for VCSE, voluntary and community sector organisation, joined the council in efforts to support the residents as soon as the COVID crisis started in the borough. And KVA itself as an organisation reorganised itself and redeployed the staff to work across 5 tiers of Kingston's Stronger Together partnership that Dr. Cross talked about. I've been given only 5 minutes, so I'm not going to go into too much detail, but specifically KVA supported RBK with what we call Tier 3 or telephone buddy scheme that supports residents with suffering from loneliness, isolation, anxiety and lower level mental health problems. Also, as we worked with RBK on Connected Kingston anyway, we supported RBK with additional COVID-related content on Connected Kingston. Our project Superhighways was very effective in supporting other organisations in the borough and actually wider in London, organising work remotely and ensuring that they can take services online as effectively as possible by setting up their laptops, sourcing their tablets. Superhighways runs Microsoft Teams training on weekly basis and continuous training and introduced new digital champion sessions for Connected Kingston. Our project Love Kingston raised £20,000 through COVID-19 emergency fund. And both Kingston Voluntary Action and Superhighways raised additional funds and brought into the borough from London Community Response Fund to better support local VCSE organisations through crisis. We also, our communication with the sector intensified through the crisis. So we've been running regular VCSE CEO network meetings, so 5 during this period. We issued e-bulletins on twice per week basis. And since the beginning of COVID, we ran 5 surveys in order to find out what the local need is and what the state of the sector is. We've also run a series of COVID-specific workshops, test and trace most recently, and this week we are preparing for the new normal at work. Both of these were organised in partnership with Public Health and RBK. And with funding from Borough of Kingston, we've been working thematic funding partnership networks with a commissioned bid writer and as a result, they've been attended by 40 people from VCSEs, and as a result, we've had one submission so far between 7 local organisations for £100,000, and this is for food. I can say that so far we've gone through second stage, and we had an interview with Lottery last week, so all that is left now is to keep our fingers crossed really tight. And lastly, I wanted to say that we are exploring with RBK safe spaces within Guildhall 2, because a number of local organisations expressed an interest to continue safe one-to-one advice giving to those of their clients who desperately need it and are not able, either due to digital reasons or mental health or for other reasons, to access this online. Next slide, please. If you click once more. Thank you. So what we've also done is set up a page on our website where we are championing and celebrating our local organisations. So as Councillor Diane White said, there have been a number of organisations that were directly engaged and still are in the delivery through Kingston Stronger Together hub and partnership. But of course, we all know that there are hundreds of organisations in Kingston, and they continued delivering and supporting their vulnerable clients. So I encourage you all to have a look at this page, because it's part of the Never More Needed initiative. And we are continuing to encourage organisations to contribute with stories, and this page will grow over time. I'm not going to repeat the numbers that Andrew has been through already, but if I can have the next slide. So our faith sector has been particularly supportive when it comes to obviously organising food parcels and cooking and freezing and delivering food around the community. So as Andrew's numbers mentioned, almost 19,000 frozen meals have been distributed through the borough. So just to mention some organisation, KT Churches, Grow Baby or Kingston Vineyard, also Kingston Food Bank, Voices of Hope and Kingsgate contributed immensely to feed those that were in most desperate need in Kingston during this period. This is just a snapshot of many, many organisations in the borough, and as Kingston Carers Network mentioned, they support 4,000 plus carers, but because of the support they were able to offer to their clients and other VCSEs were able to support, they only had the need to refer one client to Kingston Hub. Staywell, for example, received 3,679 referrals over this period and made 8,377 calls. With almost 3,000 unique clients. They also did shopping trips themselves, 798, and I think Jane mentioned earlier that they supported adult social care with hospital discharge support as well, 58 hospital discharge supporters. Kingston Churches Action on Homelessness worked really hard with the borough to ensure that 120 homeless people were given accommodation to be able to self-isolate. And 87 of their volunteers donated 881 hours delivering meals and helping with cleaning just throughout this period of COVID. 24 people were supported to move on to better accommodation. Refugee Action Kingston, 576 people continue to be supported. Obviously, all of this online with English classes, counselling and immigration advice. Staywell and Refugee Action Kingston and some other organisations also reached out to London Community Response Fund and were successful in bringing additional money to the borough. Yoda Adventures despite the fact that they work with the most vulnerable, disabled children in the borough with severe learning disabilities, managed throughout the crisis to actually develop 3 new services that were set up as a result of COVID. So they supported 65 families with parents who are key workers to access term time daycare, delivered 11 Saturday program sessions for families facing crisis, and delivered 103 family exercise sessions for children with disabilities who had to self-isolate. I'm sure that most of you are aware that Health Watch Kingston published the experiences of NHS and social care services in Kingston before and during the coronavirus pandemic report, which is and is going to be an invaluable resource for attracting further funding in the borough, amongst other things. As I'm just going to reiterate, this is just a snapshot of all the support that was given in 5 minutes. I can hardly talk about all the organisations in the borough. But to reiterate once again, support outside the hub was enormous, and because of the support of voluntary and community sector, the numbers could have been much worse had it not been for the voluntary and community sector. And the last slide, because another partner in the KSD was Volunteering Kingston. Volunteering Kingston manager Michael Green cannot be with us tonight, so he sent his contribution for tonight's presentation. And as you can see, the 3 things that Volunteering Kingston in particular wanted to reiterate, and I totally echo all of them. The first one is about partnership approach, and how well we all work in partnership, in particular the voluntary sector and Borough Kingston throughout the crisis. Hopefully, and again I echo this, I'm hoping that this will be reflected in continuation of the review to commissioning of the voluntary sector services in the borough. The second bullet point is about tapping into the enormous resource thanks to 1,200 volunteers who put their names down to support local community throughout COVID. And as it was mentioned previously, and as Michael says here, obviously we weren't able to make use of all these volunteers, but what is important that as a result of this effort, the volunteer experience in the borough has now risen to new levels, and we are sure that it will continue to thrive at least for some time. And the last bullet point from Volunteering Kingston is about looking ahead towards the end of this year and beyond that. And what we think jointly that is absolutely vital is that the core elements of the hub and of Kingston Stronger Together approach are maintained, and that the organisations key to this success retain the leadership element, whilst obviously remaining open to all civic and stakeholder contributors. What COVID-19 has shown, and I've been hearing this a lot through many meetings that I attended, is how cooperative and collaborative approaches to crisis and need can be enacted really quickly and become efficient and effective. And as Michael says, we are hoping that the hub and the KSD will continue to exist. In what form we're going to see, as Andrew mentioned, FutureGov and NLGN are carrying out the review of the hub. We have various consultations seizing the moment, etc. So what the format of the hub will be, we'll see in the future, but it will be a shame to lose this momentum of excellent collaboration that resulted in some good results. So that would be me. I hope it wasn't too long, and I'm happy to answer any questions if I can.
Thank you, San. I think we lost you just a little bit towards the end, just
I'm
for the last
sorry.
10 or so seconds. I don't know if you could just very... It was literally...
Sorry, I've lost you now. I don't know whether it's you or me. I'm not sure.
Can everyone else hear me?
Anita, I think it's you because we're losing you and we didn't lose Sanya.
Oh dear. So can you hear me? Can you hear me?
Yeah, it just went a bit funny. It's sort of, to be honest, I think it's the Virgin signal because mine's coming out. I think it's just the internet signal. It's not very good on the network tonight. So,
yes, so
you need me to repeat
hear Sanya. We were able to hear Sanya, I think. So I think the rest of us heard it. Thanks, Councillor Schaefer.
Thank you. As I'm back on board again. Thank you. I think I just wanted thank you very much, Sanya, for that. I just wanted to just mention a quick. It looked like a question or a comment, Naz. I wasn't sure if you wanted just to ask whether you had a question or not.
It wasn't that, but actually it's probably a little bit of both. I mean, the comment is, I think it's an amazing piece of work that Kingston Voluntary sector actually managed to do, and the amount of support they provided to the population was amazing. I would be just interested in knowing how much more activity was addressed during the COVID period compared to what I would call the normal activity.
Okay, so I mentioned that we ran 5 surveys, and very early at the beginning of COVID, we asked exactly that question. And I'm sorry, I should have prepared better, so I don't have the answer to that question. But we are preparing the next survey, sort of now at the, well, difficult to say at the end, but at this stage, and we will be asking the question again. But I remember that definitely the numbers of people who are being supported have gone up. We also ran a survey on food, and again, I apologize for not having statistics on hand, but there was a number of organizations that reported that they haven't supplied food in the past. That wasn't part of their activities. But through COVID, they supported their residents and their clients by either providing food or delivering food as well. I'm sorry that I don't have full answers to that question.
Thank you very much indeed for your presentation. I don't believe there are any further questions on this item. So thank you, Sandra. If I could move on to the next item, if you don't mind. I have on the next item, Sally, a presentation on the Kingston Hospital response. So if I can hand over to you. Thank you, Sally.
It's a video, so I think that you need to press the link for us, and then we'll take any questions.
Okay, thank you very much.
Is it on this slide here? Sorry.
No, we sent it a little while ago. It was on the agenda.
Yes.
Yes, actually the hospital one was going to come after the primary care one. We can do it in whichever order you want, but it'll be 3 slides on, George.
Thank you.
We did share the link as well ahead, just because I'm conscious it's a 10-minute video, so we would hope that participants might have viewed it ahead of time, but it is nice to get a flavour. So can I suggest that maybe we do a couple of minutes of it, but I appreciate it's not going to give you the full picture. Would that be all right, Sally?
Yeah.
The one before, George, please.
Oh, yeah, bear with me, sorry.
It was overwhelming. We were planning for something and we didn't know what it looked like. We went from a 15-bedded unit in one level to a 35-bedded unit in 3 areas with the same amount of intensive care nurses. So we were given a massive support team.
No, I don't think it's working.
Is this able to? Are we able to start the video at all?
Is it not playing? Can you not see it?
No, I'm afraid we can't. Not yet. I don't know if you have to open it in a different window, George.
Yeah, I should be able to do it another way if you bear with me. Sorry. Can you see that now?
Yeah, that's it.
Bro.
Thank you.
Just to see as much as we can, because I think other people have had
overwhelming.
10
We
minutes.
were planning for something
Yeah,
that we
okay.
didn't know what it looked like. We went from a 15-bedded unit in one level to a 35-bedded unit on 3 different areas with the same amount of intensive care nurses. So we were given a massive support team to all work together, and I think it worked really well.
The planning for this pandemic started all the way back at the end of February, beginning of March, when the Trust established a COVID planning group. We had enormous support in the Trust through the Gold and Silver Command teams. I always felt, as the clinical lead for ITU, that I had absolute total support from these teams. All I had to do was pick up the phone or walk up to the command centre, tell them what the problem was, and I was always amazed actually at how rapidly things seemed to be sorted out. When we put requests in for equipment and this sort of thing, redeployed staff, it sort of almost just happened, and I think it was, you know, a real credit actually to the management teams that they supported us so well.
We knew something was coming, but we didn't expect the severity and how extremely busy it was going to be, and the unpredictability of it all.
I was worried that, having been an ITU nurse, I was worried that actually working with people that may not be familiar with the environment might be stressful for them, but actually will be stressful for the already established ITU staff.
Nurses were redeployed from all over the hospital, from A&E, from the wards. We've had physios turn into ITU nurses. We've had to give some training. Most of it's on the job. They've all been fantastic.
Our support workers were amazing. They stepped in, they stepped up, and they will tell you that we have communicated nearly every day. We've been able to speak about our experiences, and that has been really, really helpful.
I thought they did fantastically because they never once showed the fact that they were worried that they had to look after an increased number of patients and had staff that maybe weren't familiar with the environment. They've been fantastic throughout.
It's taught me to be a lot more hands-on, and it's given me a lot more confidence, and especially with the team around me, they're all amazing. Nurses and staff members, all the physios, they've all been so great to me, and I think it's shown me how to work in a team a lot better.
I was way out of my comfort zone. There was no training beforehand, and the nurses were amazing. The ITU nurses worked just relentlessly to keep things going, to keep things running as smoothly as possible.
How quickly everyone mobilised and changed roles in really testing circumstances. So I was part of the proning team, which was, you know, putting people onto their front, and it was something that I had never done before. I'd seen it before. Most of the physio had never done it, and by Easter weekend there was one day we did 15 in a day, and we had come together as a team, and it became a really succinct process. And I think in stressful times, for people to learn something new and to do it successfully and safely is absolutely great.
The strangest thing was, after spending 12.5 hours with these people, you would meet somebody in the changing room, they'd speak and you'd say, "Oh, so you're so-and-so that I've been working with," but when all you can see are the eyes, I didn't know who these people were. So it's actually been lovely to meet people from all the other aspects of the hospital who've come to help us, and we thank them hugely.
These patients have been the sickest level 3, so they're all on breathing machines. Often their kidneys don't work as well, so they have required so many drugs, so many infusion pumps, alarms going all the time. Obviously, everybody has had to step up a gear just to get procurement. Have been fantastic. Pharmacy, we've had to use far more drugs and liquids and things that we've just never known it in this magnitude before.
Our pharmacy team normally top up the medicines to a predetermined level, but obviously that's been blown out of the water by the type of patients that we've had. So we've been giving a lot more certain medications, and rather going on and speaking to the staff about their needs rather than what we would normally give them.
We've increased the number of pharmacists that are trained in critical care medicine just to help support these extra inpatients in ITU. And given the increased use in antibiotics, we're also keeping a closer eye on antibiotic consumption, stock levels, and trying to maintain antimicrobial stewardship during these times. and to still make sure that we're using these antibiotics appropriately.
Families are a really big part, families and friends, loved ones, big part of our working day, but they're not allowed to visit. So we've had the chaplaincy have been on board and the junior doctors making phone calls to the families every afternoon. And more recently, when the patients are able to consent, we've set up FaceTime so they can FaceTime the families, and that's been invaluable to everybody.
Chaplaincy has been involved with the ITU for quite a while now. Over the last 4 years, we've been developing an ongoing relationship with as being part of the multidisciplinary team. So it naturally segued into what was happening once COVID struck, and we found ourselves in the middle of the real heightened response. It turned out that the best thing we could do was to support the families of the patients who were in ITU, and alongside that support the nursing staff and the consultants and doctors as they worked through alongside those patients. And we could be that engagement with the families who were often in isolation themselves, having the last thing they'd seen, their loved one being packed into an ambulance and the door closing, and they didn't know whether they would see them again. Now, unfortunately, in some circumstances that was the case, and the patients unfortunately died, and we would support them on the end of the phone. We would provide end-of-life prayers with them if they wanted that on the end of the phone. I would draft in my rabbi or my imam, whoever was needed to provide that support.
The joyous moments have been when you finally get to meet patient families and actually meet them face to face. You are that recognised voice on the end of the phone. You provide some stability and some consistency in the last however many days that they've been living through this traumatic experience. And then being able to see them reconnected with their loved ones in a garden or upstairs in a therapy gym actually makes this experience so much more rewarding as you see their smiles.
The love and support that have been shown by everybody in the hospital, the community. You know, we're being overfed. We've had cards from ex-patients wishing us well. It's been amazing.
If I was to reflect on our whole experience, and I don't want to speak for the team, but I think I can sense there's a real feeling that we've been on a roller coaster journey. Emotionally, with its ups and downs, and it has taken a huge toll on the staff.
My lasting memory is of the first patient that I intubated, who, as he went to sleep, grabbed my hand and started crying and begged me not to let him die. And it stuck with me because I was convinced that despite all our best efforts, that would happen and there would be nothing we could do to prevent it. And he survived and he went home.
I learnt so many new things, new skills, and even though it was exhausting, I came away feeling really proud that I was part of that effort. We were on the front line and everyone was doing their best to make the biggest difference they could.
From a personal level, I think the memories that I'm going to take away more than anything else is the resilience, the hard work and the flexibility of our team. Because of the increase in number of patients, we were training up junior dietitians who've never stepped foot on an intensive care unit before, and they did that without asking questions and did an amazing job. So I'm really proud to be part of that team. Because we all appreciate each other and we all support each other at the moment during this hard time. Yeah.
I'll put it in a few words here. Challenging for various reasons, interesting, heartbreaking at times. More recently, it's been relief, joy, encouraging.
The feedback that I'm getting from the staff now generally is that it's been one of the most fulfilling and rewarding experiences, perhaps, of their careers to date. We have felt very emotionally attached to some of the patients that we've come to know, some of whom have been in the critical care unit for over 50 days. And in light of the fact that their families have not been able to visit, there's been a real sense of needing to manage the patient's sort of mental well-being very much as well. And it's been incredibly rewarding as some of our patients now are leaving the critical care unit and actually even having trips to the hospital garden where they're being reunited with their families. is one of the most moving experiences we could have over this entire COVID experience.
Thank you very, very much, Sally, for that presentation. I think we can probably all agree how excellent that was to listen to that. Really, really good. A lot of work has gone into that video, and I think it was, you know, a real eye opener actually. So thank you very, very much indeed. I'm just reading a comment that we should all have a big clap for that. So absolutely brilliant. So what I'd like to do is I think there is one question that I think Dr. Miraby you'd like to ask. I'm going to bring you in now because I think the next we've got about 20 minutes before the end of this seminar comes to a close. So I'm just very, very acutely aware of time. So Liz, if you'd like to just quickly ask your question, and then I will move on to the next item, which is about the primary care response.
Yes, I mean,
thank you very much.
An incredibly powerful video. Just thinking about, you know, as we're moving into the next phase, and hopefully my questions have come up on the chat box at the side. One is about how waiting lists are being addressed and the timelines for that, because for understandable reasons, of course, they have built up considerably. And the other point is about what the separation between COVID and non-COVID services, and of course, again, that's understandable, but what that might mean in terms of any movement of services off the Kingston Hospital site, and if any of the services are moved off the Kingston Hospital site, where might they be moved to? Thanks.
No problem. Obviously, we made a decision very early on to keep our cancer work going. And we were one of the few in the country actually who did that. We managed to keep that going because of the dedication of the team, but also because Sir Willie Rouse is a separate building almost in itself. And so we felt quite confident to keep that service running. In terms of the waiting lists, they have built up, but we have a process for managing our way through them. So currently, all of the patients have been divided into what we call Ps, P1s, P2s, P3s, P4s. And we're working across South West London to ensure equity. So we've worked through our P2s very quickly, our next level down from the extremely urgent. But we know other providers across South West London have not been in the same fortunate position because of the tertiary work they do or the other things that they do. So there is work which our operations team are leading across South West London to make sure that people are done in the order of the priority, which is most important. In terms of timelines, I don't have that information on me, and I don't think that we are completely sure of how long it's going to take to get back to normal. But Mairead, our Chief Operating Officer, probably would have that. I think it's a sort of ever-moving feast, really. Within the hospital, we've got COVID and non-COVID areas. So we're using our day surgery unit to do protect a lot of our patients, so our COVID protected areas. But we have moved off to the new Vic. We did that some time ago now. I think at the start of the presentations, you heard about some of our discharges going to the new Vic. When we were able to, we've moved other services up there. We've got some community midwifery services running up there, some pain clinic running up there, and some surgery running up there, just so that we can make sure that we're cracking through our backlog. Amira's with me, our medical director, so I don't know if you want to say anything, Amira.
No, just to add to the backlog question, there have been a number of clinical networks set up across South West London, which Sally alluded to, who are prioritising the clinical need and the clinical urgency and working in a collaborative way across South West London for the benefit of all patients.
Thank you very much, Amira, for that. So thank you both for that presentation. I'd like to move on, if you don't mind. I'm having a few technical issues. I do apologise this evening if you're hearing me phase in and out. So if I experience any further issues, Iona, I may have to hand it back to you, but I think the next item on the agenda is I have as a primary care response, Dr. Annette Pout. So Annette, if you'd like to present this item, thank you.
Yes, thank you very much, Anita. So I'll be as quick as I can, so hopefully we can get a little bit more back on track. So I'll just run you through the primary care response in the initial phase of the COVID crisis. So the phase 1 response was for primary care to design and implement a single hot hub model across Kingston. In Kingston, we opted for a single hot hub model because a lot of the buildings that primary care practices are situated in Kingston weren't immediately convertible into a situation where you could keep hot and cold patients separate. So in fact, the single hot hub was created at the Hawkes Road Clinic after a short stint at Surbiton Health Centre. It was managed for us by Kingston GP Chambers, and it provided both telephone triage face-to-face, a drive-through remote monitoring service, and a hot car service, which was manned by a paramedic. In addition, we also had an enhancement of cold home visiting service by another paramedic in a car, and that was integrated into the Your Healthcare Rapid Response team in order to bolster the numbers of that team to enable enhanced home visiting and admission avoidance. As far as managing COVID-19 in general practice was concerned, all practices successfully put into place a full triage model, which consisted of remote consultations wherever possible in the first instance, and patients were brought in when necessary for face-to-face consultations, but these were in the minority. The majority of practices therefore operated a zoning system for when they did need to bring patients in for face-to-face consultations. The phase 2 response that we've headed into since the beginning of July, we had to stand down our hot hub. The hot hub had initially been facilitated by repurposing extended access service capacity, but that had to return from July back to normal levels. So we stood down our hot hub and paramedic services and developed an outbreak preparedness model. This was a scaling up of the normal extended access provision so that we could get that back to normal levels, historic levels that we have been providing before. And so these are the 3 and in fact now 4 extended access hubs around the borough. We have added a hub in New Malden. We've also developed a plan to reinstate a similar hot hub pathway should we have a further surge, and so we're busy developing that escalation plan because we would like to be prepared to be able to escalate quickly rather than have to design a plan and then escalate as levels go up. So we have had to implement the general practice standard operating procedure and infection control and prevention guidances. So all practices are working to implement these requirements to manage patient flows and to control infection risk. And all practices are operating a digital by default service or a telephone by default service where appropriate. Although I would like to just emphasize that no patient should be disadvantaged by this. So, if patients can't manage a remote consultation, we need to find a way to consult with them in a way that is acceptable for them and manageable for them. We are back to home visiting where needed for patients, so that's back to normal levels. And we have also reinstated our locally commissioned enhanced services, some with some modifications where this was necessary. So things like spirometry can't be undertaken yet in primary care, and in fact can only be undertaken in limited numbers in the hospital even. And so some of our enhanced services are back, but with a slight difference. Could I have the next slide, please? Thank you. So as far as primary care, the primary care recovery process is concerned, these are some of the main principles of that. So we need to continue to provide effective care to our COVID patients in a safe environment, whilst still minimizing the risk of infection to all our staff and patients. This means that we will be operating on a remote first consultation basis for some time still to come, although with the ability to separate hot and cold patients, we are hoping to be able to bring more patients into the surgery where necessary, particularly phlebotomy services and nursing services in general practice are up and running again, although, as you can imagine, because of infection control processes, appointment times are slightly longer and times in between appointments to maintain infection control and cleanliness of rooms. It does mean that the capacity is slightly reduced. We need to support a resilient general practice. So general practice obviously needs to remain at the heart of the NHS. And so we're going to take proactive steps to support this resilience, while at the same time we need to transform how care is delivered. And this was a process that already had been started pre-COVID and includes things like the development of PCNs, integrated care, and various other initiatives. So these are all back to being reinstated and continue to be developed. And we have numerous work streams that we have started up again as part of the recovery process, looking at things like the management of long-term conditions and complex patients and how to develop services for those patients. We will continue to design and implement new ways of working, and numerous things such as video conferencing have been very well received. You know, they were brought in very quickly. Previously, there had been some resistance to this, but COVID seems to have proved that these are viable ways of working. And so we need to support that these can become part of the new way of working and encourage people, both professionals and patients, to get the benefits from this. We need to embed new ways of working. So new innovations have been adopted, which might have been adopted rather quickly. You know, we had to do everything at speed for COVID. And so we need to give people a chance now to get comfortable with these, to understand how this new way of working should be delivered, how we can integrate it and implement it. And part of that may be to provide educational tools, toolkits and guidelines to help people to manage this change more effectively. We'll also be supporting the business as usual of general practice. And one of my colleagues pointed out the other day that business as usual is going to be somewhat modified for the near future, but it's as close as we can get to business as usual at the moment with the restrictions that are still in place at the moment. So we'll ensure that practices receive the support that they need to deliver the contractual requirements that they are required to deliver under the current circumstances. And I will stop there, but happy to answer any questions if we have time to. Thank you.
Thank you very much, Jeanette, for that. I don't believe at the moment I have any questions in the chat box. If I do get any further comments or questions between now and the end of the session, I will of course email them to you, Annette, to see if you can respond that way. But at the moment I don't have any. So I would like to, if you don't mind, I would like to say thank you very much for that presentation, and I will now hand over to Iona. Thank you.
Thanks very much, Chair. So onto the last straight here. So again, looking forward and plans that are in place now. So if I could have the next slide, please. I think it's the one with the forest fire on, please, George. That one, lovely. So this is the Keep Kingston Safe, our outbreak control plan. So there's a requirement for every area to publish an outbreak control plan by the 30th of June. The command came out on a Sunday evening late at the end of May, at the start of a half-term week. So it was quite a chase to produce it in the time because it is a partnership plan. And it has 4 main purposes. And really what it's doing is looking, obviously, when you can see in that top graph, when the virus was spreading very wildly like a wildfire, we then had lockdown come in and you can see it tailing off. And the aim of the outbreak control plan is kind of to stamp out the remaining embers of any little fires out in the community. Because we don't have a vaccine, we still have lots of people that are susceptible to the virus. So we've got lots of dry grass ready to ignite around any embers of infection. So our outbreak control plan is a local plan to make sure that we get notice of any outbreaks very, very quickly, and we get on top of them very quickly, so you don't get onward transmission and you don't see the peak start to go up again. So the 4 areas are supporting the national search for any existing cases. So we have a large programme working particularly with our community and voluntary and faith sector to get a message out to all of our residents that if they develop symptoms, they should go home, self-isolate and book a coronavirus test, and making it really easy for them to know how to do that and where to get tested. And we have the benefit of having a regional testing unit at Chesting World of Adventures, but we also have a mobile testing unit that's in Kingston, usually 3 or 4 days out of every 7. So again, it shouldn't be difficult for people to get testing at either of those sites, but there's also home testing as well. We then need to support those cases and their contacts that need to self-isolate, so offering them support, recognising that it's their kind of civic duty to try and stop this onward spread again, that they won't be penalised from self-isolating, so offering them support, and again through our Kingston Stronger Together hub for those that don't have it available for anyone else. We've been preparing outbreak management plans, so that's plans, detailed plans if we have an outbreak in a particular setting, like a school or a care home, but also in workplaces, in community settings, so that should we get a flare up, we've got programs that we can put in place to quickly get on control of an outbreak. And you'll have seen places like Leicester and Blackburn, where we've seen these sort of surges of cases, and I get daily updates in terms of cases in Kingston, for example, and really keen to try and get as much information. It's just beginning to improve that data flow from the centre regarding information of any local cases, and it's still very small numbers at the moment for Kingston, but clearly the more people are tested, the more we are potentially going to find cases. And so what we need to do is support the implementation of these outbreak management plans if we do get an outbreak in a setting, and people working together. And I think feedback from those areas where they have had outbreaks is it's actually using a whole collective response, engaging with people and letting them know why they can make a difference to get on top of an outbreak quickly. So just to say, it was published on the 30th of June. It's available on the RBK website, and it's the Health and Wellbeing Board that's kind of the overseeing gold command for our outbreak control plan. So communications involved with that, and making sure every partner knows their part to play. So I'll pause there. Thank you.
Thank you very much, Iona, for that. I have one question, and it's from Councillor Bass. Thank you.
Thank you, Chair. Yes, Iona, just one question. Obviously, during the lockdown, there was a lot of information easily accessible for residents, and some residents of mine have asked, where's the best place to find the current R rate, both for Kingston and other parts of the country?
So there is the government website, the Public Health England dashboard. They've been updating all the time to have more data pulled together. It won't be down to an individual borough R rate, because somewhere like Kingston has quite a small borough, and actually a small number, change in the number of cases will actually make it look like it's jumping up very quickly. So you have an R rate for London. What you do have is, are you observing more positive cases than you'd expect? So it's something called an exceedance report. So I would get to find out whether Kingston was creeping up the exceedance report, and somewhere like Leicester is many times ahead. But the public government website is actually where you're going to get the most data in the public domain, and it's updated on a daily basis. I can share the link round, after the meeting, Councillor Bass.
Yeah, thank you. And yes, please do share it.
Thank you very much, Iona, for that. There are no more questions on this item. So if that's good to go, I'd like to now say thank you, Iona, for that presentation. And over to you, Naz. Thank you very much.
Hi, I don't know whether we've got some slides. Yeah, that's great. So just very, very quickly, obviously, Kingston and underneath the remit of the Health and Wellbeing Board produced a health and care plan. Now, obviously, because of the COVID impact, there are certain elements of it that we need to look at to see whether we should stop, start, or even continue with elements of the plan. So we've got to look at the priorities going forward, and I would suggest that over the course of the next few months we do that. The other element is actually look at the new priorities in in response to COVID and the learning that has come out of it as well. So particularly we need to focus on the addressing the inequalities. I think the Borough and also the NHS have done sterling work in trying to address some of the inequalities. I think there's an awful lot more work that we do need to do. And part of that is actually looking back on the COVID-19 pandemic to actually see what we can do to try and protect particularly the BAME population, and also on the restart processes, as has been discussed previously with the primary care element and the secondary care element, about making sure that the inequalities are not widened when it comes to actually looking after our population at most need and the most vulnerable. Lastly, just to let you know that we are going to be refreshing the view on this, as the health and care leaders are due to meet on the 3rd of August. And this is following us having become a single CCG in South West London on the 1st of April. So the Borough Committee, which is the Kingston base of this South West London CCG, and part of the care leaders from that Borough Committee and the health and care leaders across the system are going to be meeting on the 3rd of August to discuss how they'll take the work forward and take on board the recovery and the objectives of the South West London Health and Care Partnership, and particularly focusing around the health and care plan that has been developed in Kingston. So there will be a refresh of the plan, which we'll be bringing back to the Health and Wellbeing Board over the course of the next 2 to 3 months. And that part of that plan will be looking at the learning that's come out of this, and also making sure that we address any inequalities that have appeared through this crisis. So I'm not going to do any more than that. It's 9 o'clock in the evening, and I do want people to be able to just have a minute or two to be able to ask questions. But ultimately, I do realise that we have gone over by 30 minutes. So just hand you back to Anita and Fiona.
Thank you so much, Naz. I haven't got any questions in the chat box, but should I receive any after the seminar, because it is late and we've gone the whole stretch this evening. I think it's been an extremely useful meeting. I just wanted to make 2 very, very quick comments before handing finally over to Iona. I think we are seeing a way that we've had to adapt to absolutely unprecedented situation for all of us, our healthcare partners like yourselves in GP practice and so on. I think there is a time of reflection at the moment to see what we've learned and how we can move forward with perhaps different methods of working, different ways of working, and I think that's going to be key moving forward. So I just wanted to say thank you very, very much to all our presenters. I thought that was an absolutely fascinating evening, extremely interesting. Thank you. You know, there were excellent presentations. I hope that we all have sort of come away from this with a better understanding and an overview, if you like, of really the current status and what we've learned from that so far. So I am going to end my bit, and I'm going to hand over to Iona, really, perhaps for some summing up. So thank you very much indeed, everybody. Over to you, Iona.
Thank you, Chair. I appreciate it. It's been a long session. I think a very rich and fully packed session. I hope colleagues have found it useful. It is only this first phase, I would say. We do, as I mentioned at the very beginning, we have COVID-19 with us for quite some time, and it's something obviously that the Health and Wellbeing Board will be looking at, as Naz has said. When we look at our health and care plan refresh, it will be on our agenda. We will be looking at through this lens of inequalities. So that to look forward to as we get around to a more normal running of meetings, and clearly that intention. And it's been great that we have had people on the live stream. You know, whilst 9 isn't a lot of people, it's a lot more than we sometimes get when it's at the main Guildhall. So I would also say that. So I would also say thank you to all the colleagues, and thank you everyone for their presentations this evening. Thanks very much. Good night.
Thank you. Good night.
Thank you, Iona. Yeah. I think on that note, we shall say good night to you all. And thank you very much indeed. And I echo what Iona was saying about the public listening in this evening. Thank you all very, very much for your time and energy and enthusiasm.